wonderful to be here with all of you. Thank you so much for inviting us, and thank you so much for your leadership in holding this forum and holding all of us accountable to provide the appropriate, highest quality care at really the best prices for all of our communities. So I'll answer the first question first. We started even before Chapter 224 to focus on meeting the cost growth benchmark. We sat down with the local payers, we reopened our contracts, and we gave back rate increases that were promised to us for coming years to the tune of $350 million over 4 years. At the same time, we took out $300 million of direct costs, unit costs, from our overall, costs in our system. And we also, in those contracts, tried to move away from fee-for-service medicine in the vision of the Affordable Care Act, having shared savings and taking risk in all of our contracts. We also embraced the President's vision, the Affordable Care Act, by becoming one of 32 pioneer accountable care organizations, one of 5 organizations in this marketplace that did so, but also really the largest and really single largest academic health system to do so. And in the very first year, we created $14 million of savings, and at the same time having high quality outcomes. We started to move to redesign the way in which we provide care. We took all of our primary care and moved towards something called population health, looking at the problems that our primary care patients had throughout the system, and changed our primary care practices, and we're doing that throughout the system, first to patient-centered medical homes, so we have coordination of care, finding where there's chronic illness and other problems, and not just providing service on an interactive basis, to move away from fee-for-service medicine. And the second, as Charlene talked about, people who have high-risk problems consume a lot of healthcare services. In Medicare, 10% of the population consumes 70% of the resources. And we embedded in all of our primary care practices high-risk care managers to coordinate that care, to get the right care in the right place at the right time, and also embedding the highest quality behavioral health services on the planet to be able to focus on mental health and substance use disorders within primary care and throughout our system. In the second question, you've heard that a number of the reports, the publicly reflected reports, have focused on our prices. The focus of Chapter 224 and the Affordable Care Act is on total medical expense, not on prices. So it's getting the right care in the right place at the right time, not necessarily on what the price of each of those services overall. And if you look at even the most recent report from CHIA, which reflects services only through 2011, which was before we started to make these investments and before our contract reopening, you'll see that our total medical expenses are only a small distance from the median relative to what our price differences are. And that means that our coordination of care, even before we started to make these investments, particularly focusing on high-cost care, was in fact quite good. But we've made substantial progress. If we look in 2012, our health status adjusted total medical expense actually went down by 0.7% for the year 2012, and we beat the AQC, the Alternative Quality Contract 2012 trend for the rest of the marketplace. We expect absolutely the 2013 to be below statewide benchmark. We will continue to focus on cost. We will continue to focus on quality of care by redesigning the front end of care, by coordinating care and getting the right care in the right place, so that there aren't those bills from all over the place, but so that there's a focused, communicated effort to focus around our patients' needs, around their problems, and in making sure that we get the right care in the right place at the right time. Thank you very much.
The final hospital leader to address us will be Dr.